I think we have an evolvement of the treatment strategies. Actually the first-line therapy, the standard in first-line therapy was crizotinib. Then there was the alectinib versus crizotinib trial showing that there's a PFS benefit with alectinib. It triples actually the PFS from 10 to 35 months. So I think this is very convincing. Now we have the brigatinib data. Brigatinib is also a kind of a third generation TKI, and these data were already published or presented at WCLC, and they are also published in the New England Journal, showing pretty identical efficacy also in the CNS as with alectinib. Now I think we have a total of 5 different ALK inhibitors that actually are accessible at least to the patients in Europe. So now we have to really look at sequencing correctly these different ALK inhibitors. So at least in my practice, more and more resistance testing comes into place in ALK positive patients in order to stratify the right therapy. So the right next ALK inhibitor once a patient is resistant against the previous ALK inhibitor. I think what really is difficult to address in licensing or registration trials, because there you only look at one line, but what's really important for the patient is the sequence. So what impact has one line on the following treatment, and I think this gets more and more into the focus of doctors and hopefully also of how to design trials.